Okay, we'll call this meeting to order for the large DCCJC group for May 30th of 2024. Do we want to go through and introduce ourselves? I think we could maybe start with you, Katie.
Yeah, I'm Katie Shelley. I'm a clerk report in Dunn County. I'm Chris Corporal, the county manager.
I'm Chris Meyer, Dunn County Circuit Court Judge, Branch 2.
Rick Collins from Omni Chief of Police. Sean Askamp, Sergeant UW Stowe, here for Lisa Peterson, our chief.
Jim Peterson, Branch 1, Judge.
Randy Jack, Mayor.
Janae Brentner, Dunn County Top Coordinator. Jill Gamez, Executive Director at Arbor Point.
Jamie Nardine from the Branch 12. Maria Hurl, the Victim Witness Coordinator.
Andre Nodoff, the District Attorney.
And Sarah Benedict, Criminal Justice Coordinator and Director of the Division of CJC. Admin. Sorry, it's a lot to say.
Do we have any public comment?
Not that I'm aware of.
So I guess we'll move down to Jill or Janae.
We're gonna start with Janae.
Okay. So Janae is gonna talk to us about Narcan training.
But
Essentially, the couple-minute video here is really all that you need for Narcan training, but everyone that comes into our office for programs, referrals, we train them in Narcan, whether or not they need it for them or someone around them. We always say you can't Narcan yourself, so for all of us to carry it in the field that we work in, I think is also important. So just by this couple-minute training, I got a couple other quick follow-up points, and then if you guys have any questions, it should be a quick and easy training, and then I've got Narcan bags for everyone here.
So everyone's gonna be trained in Narcan, certified after we're done here. If I can work.
All right.
Do we have anyone by Zoom?
No. Okay, hold on. All right, so I've got to do a share. Okay. Let's see, Katie, how do I get the volume? Share. And
Are you in Teams?
we're in Zoom. Okay, here it is. Share sound and optimize. There we go. All right. Now do I turn my speakers on?
Nope, you should go through the system here.
Okay. Okay, it's interesting. It's moving on mine. Oh, it's
Can't wake them by yelling their name or rubbing your knuckles on their chest, give Narcan. If they're not breathing, open their mouth and remove every 5 seconds and continue this for 30 seconds.
okay, here we go. It's a 2-minute video if I can get it going. So. Anticipation.
Does it show up on the screen?
Overdose. Are they alert and awake? Are they breathing at all or very slowly? Do they sound like they're snoring?
There you
All
go.
right.
Hey, Jim.
That's quite a picture.
Yeah, that is picture, you know. You're out there, the two of us.
The
were-
dream team.
Yeah. You can see Judge Musa.
Yeah, there you go.
Or gurgling? Are they limp with clammy?
Okay.
Here's how you can safely administer Narcan. First, you need to know if someone is having an opioid overdose. Are they alert and awake? Are they breathing at all or very slowly? Do they sound like they're snoring or gurgling? Are they limp with clammy skin? Are lips or fingertips blue? If they have any of these symptoms, call 911. Follow the directions they give you. Let them know if the person has stopped or slowed breathing. If you can't wake them by yelling their name or rubbing your knuckles on their chest, give Narcan. If they're not breathing, open their mouth and remove any objects in it. Tilt their head back, lift their chin, pinch their nose. Give one breath every 5 seconds and continue this for 30 seconds. If the person is still not breathing on their own, give Narcan. It's simple. Just remove the device from the package, put the tip in either nostril until your fingers touch the nose, then press the plunger. Continue giving rescue breaths. And if there's no response after 2 to 3 minutes, give Narcan again. Sometimes it takes more than one dose. Once they're breathing again, put them on their side with their top leg and arm crossed over the body to prevent choking. Then stick around until emergency help arrives. Remember to keep an eye on them constantly until emergency help arrives. They should be monitored for another 2 hours after the last dose is given. This is to make sure breathing does not slow or stop, because the dose can wear off and because the chance of another overdose is possible.
A couple things I like to touch on with people. Here's an overdose. If you give someone Narcan, I could take 2 doses of this right now and it's not going to affect me at all. I know a lot of people worry, what if I have this with me? Are the police going to think, oh, they must be using something because they have it? I carry it with me everywhere in my vehicle. I've got it in the office. Again, you never know when you're going to come across a situation that someone may need it. Good Samaritan laws prevent the person from calling 911 from getting charges unless they have a warrant. And it's not illegal to carry Narcan. So last thing I tell people, if someone is actually experiencing an overdose and you give Narcan, that's again, good reason to have 911 on the way. It's going to throw someone into instant withdrawal. So people can get really irritated and possibly aggressive right away because they don't like that feeling. So each one of you can take one of these bags. I'll just track how many we hand out, but in each one of these bags on the zipper, we've got the CPR face shield. So if you do have to give CPR, there is a face mask on here. On the inside of each one of the bags, there's 2 doses of Narcan. Past these are on 2. So these are just my trainer ones. These don't have anything in them. But just to get a feel of what it is, it's essentially you put it in the nostril up until your finger touches and then push down the lever. So there's 2 of them in each one of these bags. Like I said, you can always give another one. It's not going to hurt anything. And also if they fall back into unconsciousness, you may need a second dose. Gloves in here in case you need it. And then also in every one is the specific directions from the box as well as serial numbers, everything like that. So anything you should ever need. We do put our quick little Narcan card in there too. Just business size card of how do you know if it's an overdose and a quick how to of how to use the Narcan.
How expensive is it and how do you get more of it if you needed it?
Yep, so we get all of ours from Public Health Dunn County. They've also got the vending machines out there as well. So we aren't really buying Narcan at this point. If you're on Medicaid, it is free. Otherwise, co-pays, if you're on, say, a private insurance, can be between $5 and $30 per dose. Again, no public health anywhere has them free. There's vending machines kind of going around everywhere now. You can always get that supply for free as well.
So other than opiates, what else can this help with?
So only opiates. The big thing is xylazine now. This will not help with xylazine. However, most xylazine that you're gonna see is also gonna be mixed with fentanyl. So yes, opiates only.
And what if you give it to somebody that is not having opioid use overdose?
Yep, like I said, I could take 4 of these doses right now. It's not gonna do anything to me. It's only gonna affect those opioid receptors. So if there's nothing to block it, it doesn't hurt anything.
How prevalent is opioids versus heroin or any other overdose?
I think that'd be the number 1. Again, we're starting to see fentanyl mixed with most of our stuff. Methamphetamine being our number 1 use of drug here in Dunn County.
So it won't help that any.
No, however, there are a lot of people coming in with primary use of methamphetamine that's being cut with fentanyl now, and they're not knowing that.
So nationally, when we look at the numbers of overdoses, 1/3 of overdoses are from a combination of stimulant and opiate. So they could be using, methamphetamine, but it has fentanyl in with it, so.
Is fentanyl
Fentanyl is an opiate,
what is
and
it?
heroin is an opiate, or like oxy, you know, some of the prescription drugs, those are opiates. It's all the opiate class.
That's,
Opiates and opioids, right? Opioids being what are those?
Synthetic.
Yeah.
And I guess I would just add that from what I've been hearing about the overdoses, a lot of them are counterfeit pills that people are thinking they're taking one thing, and it's fentanyl or a hot spot of fentanyl in that pill, and that's what can produce an overdose as well. So there's that one pill can kill campaign that you may have heard in the state. I know Stout is making efforts to make Narcan available as well. It's just really somebody that's not knowing what they're taking can get themselves in an overdose situation, and that's why just the more we can train and make it widely available, it can really save lives.
For the handful of people that we've heard use it within the last probably year or so that we've been doing this has been, I don't need it, that's not the drug that I choose, but 4 out of 5 that I know of have been actually use of meth that resulted in overdose from opioids.
And historically, you know, overdose death from methamphetamine was uncommon. You might have a stroke or a heart attack, but to have an actual overdose death wasn't necessarily the, as related to methamphetamine use. It is with opioids though. And it's just the fentanyl, it's that synthetic, it's in everything. It's cheaper, it's widely available, it's just mixed in everything. And a lot of people are calling it poison. The drug supply is poisoned if they don't know what's in it.
is there a straight up fentanyl? Is there straight up fentanyl pills too though?
Yes,
So those, but is that cut with something else then, or is it just straight up
that's just
fentanyl?
straight fentanyl.
And what does fentanyl do to you versus opioids? I mean, why is it?
Which opioid? It's a
Pain.
simple nervous system depressant, so.
The medical
Put
use
you
for
out.
fentanyl is going to be anesthesia.
Yeah, they said it's widely used in the medical fields, usually patches or some, you know, less, probably not a pill form.
Anesthesia, cancer treatments. And
Mhm.
yes. Just the tip of a pen amount of fentanyl can kill someone. Yeah, very dangerous, and it's definitely around here. Like I said, we test everyone now, no matter what their drug of choice is, for fentanyl in all of our programs. On every single standard test now, because it is becoming more prevalent.
You know, that being said, I wonder if it would pay sometime to have you come up to City Hall and we do, you know, Wednesday mornings, we have a staff meeting. Might be kind of fun to have you come up and just do that for our staff.
Yeah,
The more awareness, the better.
Mhm.
Have
Yeah, and
you
I
ever-
can train anyone, whether it's someone in recovery, family members, professionals. I just can't train the trainer, so like I could train you to become a trainer, but I can train anyone with my certification. So,
Have you had the opportunity to reach out to like Joe Zadowski or anything like at the high school or the schools
no.
for the teachers and staff? I may recommend that you reach out to Joe Zadowski, the school administrator, and see if they would want a training for, you know, their teachers and staff. I think it would be worthwhile, because you never know.
Yeah.
If they save one life, it'd be worth it.
Yeah. Absolutely. And I believe the doses that are in these bags go until 2026, so there is expiration, but they go for quite a while. If you ever need more, like I said, contact the public health, then we can get you more doses if you need.
Do you know if there's a temperature sensitivity to this? So like if I keep it in my car and it gets cold in the winter and hot in the summer?
Yes, so do not let it freeze and do not let it overheat. If it freezes, you're gonna have to wait for it to thaw out to use it. It's gonna be the problem. Small dose, so it may not take super long, but if you're needing it, you're needing it now. Super hot, I think it's 90 degrees is what they don't recommend past. So 30 to 90. So yes, but yes, with our cold winters, I say, put in your purse, put in your bag, keep it wet, that's rather than freeze.
Chief Hollister, do the police officers carry this with them?
Yep, they would train, every trainer.
Okay, so I take part of this too.
Yeah.
Thanks, Janine.
Thank
Thank
you.
you.
So we're all certified.
Yeah, I'll take my two little practice ones, so I can
Wow.
continue using those, and
There's that.
you guys get on with it.
Jim stuck this one in his nose, so.
Gee.
We'll actually go.
Thank you all.
All right, Jill, up on to you about what's going on at Arbor.
All right. Well, I have been told that the best speech is a short speech, and I think my speech will be mediocre.
Pharmacy for drugs and whatnot.
Sorry, we're probably on the next YouTube video out there. I have no videos, but yeah, I do have slides. So when Sarah asked me to join and give updates from Arbor, I'm like, sure, I can do that. And then I started thinking of, oh, I gotta tell them this, I gotta tell them this, I gotta tell them this. But you're gonna fully enjoy everything that I have to share. And you're gonna love the mediocre speech. So advancing forward program highlights and updates, information pulled together just for all of you. Oh, no, here we go. All right, so these are the things that I want to share with you today. I do want to give you an introduction, just some basics about Arbor. I think most everybody here knows what Arbor Place is, but some additional information never hurts. And then I want to highlight some of our new programs or services that we have going on. So that's going to be Seeking Safety. I'm going to talk about our new medical director, Dr. Hessenberg. SOAR CM, it's just part of our alphabet soup. State opiate response contingency management. I'm going to talk about some of the women's work that we're doing, and then most exciting is groundbreaking. Okay. So I thought to tell you a little bit about Arbor Place, I'm just going to start by going over numbers. Numbers, we all love numbers. Arbor Place, 48 years old. 48 years ago, a group of people decided to establish what is now Arbor Place as a nonprofit organization. I've been there 23 years. It shows you that I'm very comfortable in my routine that I have. And there's always new stuff to do, things that we can do better. So I continue to do the work. Total staff is 47. When I started, we were about 24. So we doubled our staff and correspondingly probably doubled our programming. We're licensed for 8 different services or programs. That includes high-intensity residential, substance use disorder treatment, low-intensity residential, day treatment services, regular substance use disorder outpatient, mental health outpatient, prevention services, and then 2 services related to intoxicator driver programs. We have 32 residential beds. I know I'm so full of numbers here. It's okay. Right now we have 32 residential beds. That breaks down to 18 for men and 14 for women right now. And in 2023, we had 290 treatment episodes. That equates to about 290 people. There may have been a couple people that came in for more than one treatment episode, but it's pretty darn close to that 290 number. Continuing on with numbers, we have 2 outpatient sites, the main one being in Menominee, the other one being in River Falls. And in 2023, we had 757 clients come in for at least one service in outpatient. So our numbers are looking really good. Although we still can't get people in for services fast enough. So we always try to improve that way. In our outpatient programming, we do have 5 group programs that we run between the 2 sites. And this equates to 13 different group sessions that are offered each week between Menominee and River Falls. We are piloting a contingency management program, which I'm going to talk about a little bit more as I go on in this presentation, but that cohort has 14 clients in it. We are engaged in a project where we're looking at how collectively we can serve women better with substance use disorders. And so within our work across this region, we have over 70 people that have attended at least one of our meetings, which is really great to be able to engage different people in
the conversation of how can we serve this population better. And we will have 20 new residential beds next year. And I'll get to that a little bit more in the end. But that all brings us back to number one. Arbor Place is number one, or at least aims to be your number one provider in this area. How's that for numbers? That's good.
That's good.
You like that? Okay. All right. So, some specifics about programming. Seeking Safety is a, program curriculum that we were asked to, implement by the treatment courts. It is an evidence-based, treatment approach. We, had a counselor that was trained as a facilitator. It is a program that is evidence-based for co-occurring trauma and substance use disorder. It really focuses on establishing safety and coping skills in order to hopefully reduce the use of substances as a coping mechanism. We have it set up so that they're 90-minute group sessions once a week for 16 weeks. We started in April, and right now we have 8 clients engaged in that group. I think as of right now, we have maybe 1 or 2 clients that are in the treatment court systems that are in that group, but we're really happy to be able to offer that service, especially since it is something that was requested of us. Right now, we're running it just for women. We do have plans for trying to launch a group specific to men also. Our new medical director is Jill Hassenberg. So I'm used to really only being the Jill at Arbor. And now we have at least Dr. Jill. She's always Dr. Jill, and I'm just the Jill. No. But I feel very fortunate to have her on board. Our previous medical director was wonderful also. Jennifer Bassett, she is a medical director for the methadone clinic in Eau Claire also works as a family practice doc. She just didn't have the time to see patients with us. Dr. Hassenberg worked at Ellie Phillips since 2017. So when they closed, I was like, you need to come to Arbor Place. We need you. And thankfully, she was willing to do that. So we do have her on board with a lot of expertise about withdrawal management, as well as prescribing medication-assisted treatment, so Suboxone or Vivitrol. She does not prescribe methadone, just because that's a whole different certification to operate a methadone clinic. What I can tell you is that, so she's our medical director as well as providing direct services to residential and outpatient. What we have noticed since Ellie Phillips closed is that, and this of course wouldn't be any surprise, we get more people coming in to admit for services, and they are still struggling with withdrawal symptoms. That is the #1 reason why people decide to leave treatment within that first week. Those withdrawal symptoms can be really uncomfortable. And one of the main goals of a detox program like Ellie Phillips had was one, of course, the physical safety and physical and medical safety going through withdrawal symptoms, but it was also to help someone get over that hump of the withdrawal symptoms so that they can engage in treatment program. So now that we have Dr. Hassenberg, we at least have some on-site ability to prescribe some medications that may have otherwise been prescribed in detox, help them get over that hump a little bit. By no means are we a detox program, but once I get this new treatment unit built, that's probably my next goal. Unless by some miracle, we have somebody else step in and say, yes, I'll do it. I don't know if I see that happening. Next is to talk about this SOAR CM. So again, it's State Opiate Response. That's a specific grant that the Human Services gets, and then they include in our contract to specifically work for and with individuals in Dunn County with not just methamphetamine, but stimulant use disorders and opiate use disorders. What we know is that contingency management is a treatment approach that's found to be really effective for stimulant use disorders. And I know that, within some of the treatment court approaches and other diversion programs, contingency management is pretty common. But in its simplicity, it's rewarding behavior that you want to see. I mean, it sounds really simple, but they've studied it quite a bit in treatment to see if it's effective, and it is effective for stimulant use disordered people. So it's a little bit more of an expensive approach, although not expensive when you think about medical approaches overall. We started with a small cohort group because we wanted to see, is this going to work? What we've designed is a 12-week program. It's implemented along with other approaches. So it's not just that they're doing a contingency management program. They're doing their individual counseling, maybe individual therapy, maybe group sessions. It's all in outpatient. And we're targeting 2 behaviors. The first one is completion of digital CBT or cognitive behavioral therapy lessons that they can do on their own. And the other one is having drug screens that are that indicate no use of stimulants. We don't look at other drug use. We look at the stimulant use. So that took us a while to kind of get our head around, because it's a little bit different approach than requiring complete abstinence. And then, so those are the 2 behaviors. Over the course of 12 weeks, when they complete a CBT lesson, or they give a urine sample that shows no use of stimulants, there's a gradually increasing reward that they get. And at the end of 12 weeks, they can earn up to $465. So like week 1, if you your test shows no use, great, $5. Come in for a second time this week and we'll test you again, great, another $5. By week 10, let's say, they're not getting $5 anymore. Now they're getting $20. So it gradually increases, right? So at first I thought, well, why don't we give them bigger rewards right away? Like, isn't that the time where you like really want to catch them? But that sustained non-use, those pathways in the brain of that reward system is so heavily established in their brain that we have to try to overcome that, to say this reward of cash and praise is more valuable than the short-term high than you're gonna get. So right now, like I said, we have 14 clients enrolled. All of them should be complete with the program by August 1st. Then we'll be able to take a look at all the data to see if it shows more effectiveness than not doing this intervention. I love this stuff. Anecdotally, we are getting really good feedback from clients. Even if there's use, they're still coming in. They're still coming in because it's not a punitive. We don't take money back from them. We just say, okay, let's start again. We just start again and work it on up this way. So I think it's pretty exciting. Okay. This next piece is a mobile, right? So I'm going to jump into talking about some of our women-specific work that we're doing. If you think about this mobile, it really can be a metaphor for the family. So we know that substance use disorders impacts the whole family. And when you remove one of these things, the whole mobile does not flow as nicely as maybe it should, right? Someone goes off to treatment, they come back. The whole family system is also impacted. But in the same token, when we think about working with women that are pregnant or are parenting, our systems also need to do work in order to work really nicely together. And that's a lot of work. So what we're trying to do within the region is really to facilitate those conversations about how can we better serve this population of women that are parents or soon to be parents that have substance use disorders. And as I said in the intro, we have over 70 people that have engaged in this conversation so far. What we've broken down into are 6 work groups. So the first work group that we have is focused on reducing stigma. One thing that I heard just a couple of weeks ago, it really stuck with me. It talked about when we look at an individual and we look at the factors that are predictors of if somebody is going to be successful in reaching their own recovery, we often look at their individual factors. Do they have a criminal history? You know, maybe some of the ACEs things. Were their parents divorced? Do they have a substance use disorder? Do they have mental health? All those individual factors. But what we're missing is how helpful are the helpers around them? How helpful are the healthcare professionals around them? How helpful are our service providers? And that is just as much of a predictor of success for a person as those individual factors. And this really relates to stigma. So if I jump back to thinking, or to what I said about this contingency management, and that somebody can earn, you know, almost $500 just for not using drugs. If somebody had a thought in their head, like, well, why should we pay these people not to use? Like, they shouldn't be using any. That is some of our internal dialogue that relates to stigma. If we think, well, they should just be able to stop. They're not, you know, they're not worthy of this or whatever. It's that stigma. And so are we really trying to provide them with as much help and hope as we can? Because we impact their likelihood of recovery just as much as they do. So addressing stigma is really important. The work group that we have, we're looking at holding some lunch and learn events to start to challenge people a little bit more to uncover their own biases. We all have them. And think about our own language that we use. Do we say addicts or do we say persons with substance use disorders? Do we say that they're resistant or do we say, you know, use other language? There's all kinds of those language things, but it really colors how we and others look at this individual, especially pregnant women. And then we're also looking at developing a toolkit that could be used within organizations if you want to try to continue that conversation going about challenging our own stigma. Another area that we're looking at is screening and identification. So providing tools so that different organizations like the Bridge to Hope or you know, other service organizations can start asking those questions in a regular routine manner, especially for pregnant women if they use alcohol or drugs. And if you match that back with stigma, it's asking in a non-judgmental way so that we can connect them to services and help. And of course, always looking at the resource listing, because we're looking at this from a regional approach. We want to make sure that other people in the region know what all the resources are. Continuum of care, looking at not just what's available for substance use disorder treatment, but what's available for other support services for this population. Looking at peer specialists, is there a training that we can provide specific to parenting and family services that could benefit peer specialists? Promoting the wraparound case management support, looking at parenting programs and family safety planning tools. So there's different pockets of providers and organizations that already do really good stuff with this. We just want to talk about it more so that Arbor Place can grab, oh, we should be doing this, right? Instead of just individual safety plans, we should be doing family safety plans. We're looking at legal and policy. There's a lot of confusion around if it's a mandated reporter requirement for a pregnant woman who's using. There's questions around the constitutionality about the law for things as they relate to the U-chips. I mean, there's a lot of legal questions. And so if we're asking people to start screening more women, we also have to know what the legal ramifications are. Treatment approaches, again, exploring what are really great treatment approaches to use with this population. And then the last group that we have is looking at harm reduction. So certainly the use of Narcan is a harm reduction approach. But it's interesting to start thinking about, okay, so we talked about harm reduction, but where's our level of tolerance for harm reduction when it comes to pregnant women or parents? What are we willing to kind of work with and what are we willing not to work with? Harm reduction is all about meeting people where they're at. And that gets a little bit more complex when you're also considering that there's children or an unborn child. But at the same time, we want that person to be alive so that they can experience recovery in the future. We do have a page on our website that we're dedicating to this project, Health Disparities in Pregnant and Parenting Women. We have a calendar on this page too, so if any of those work groups sound interesting to you, this is where you would go to get all that information about when we're meeting, etc. So all of that work that we're doing in terms of how to better serve this population is working in tandem for us to plan to build our new treatment unit for pregnant women and women and children. So this is our first rendering of what that will look like. Thumbs up. I just got this in my email today, actually. So it'll be on the same location as where Arbor Place is located right now. It'll be on the east side of the property. It will just be for women. So our women's unit that we have right now for residential, all of our women will move over here. It'll be 20 beds in 10 bedrooms. So it'll be able to flex to either have 2 women in a room or a woman with her child or children. So it could be 10 women with their children, or it could be 20 women altogether.
Is that a rendering of your existing facility behind it, or is that part of that facility?
That's part of that facility. Yeah, the first level, the first level here will be kind of similar to what we have for outpatient right now. So it's like a big group room. We'll have a child's care area, some individual offices, but the residential portion is up on the second level up here, and that's designed very similar to our existing residential facility with the bedrooms and kitchen and living room and so forth. And then counselor offices up there too, an exercise room. Yeah.
Sure, what's your date, completion date?
Completion date is about 12 months. So we have our groundbreaking on June 13th. I think that they will actually, which I emailed the invite to you today.
Oh, today, okay.
So once they actually, of course, this is ceremonial, but once they actually get going, our existing facility took them 12 months. So this one is a bit smaller, although much larger than I first anticipated it to be, but so it's still about 10 months, I would say, on the quick end, but 12 months probably on the more realistic end. So start this summer, open next summer. And I think it will, I don't want to say I think, I know it will give us a tool to be able to do something different than what we maybe sometimes have to do right now with families. I know one thing is that it always, it never sits well with me when we have a pregnant woman in right now. And if she stays up until her due date with us, she can't come back with baby. We're just not set up with our programming and so forth to be able to do that. So that means if she delivers and then comes back to us, that means she's coming back without baby. And if she doesn't come back to us, that might mean that she's still with baby. We have a person new in recovery, new mom, and what, like fingers crossed, like, So I'm really hopeful and optimistic that this will give us a new tool to think like, could we keep some families together? We know that there's the additional support and programming to surround them during that, really important time, either right after birth or, if they're toddlers.
You had shared a lot of numbers, beds and such.
Yeah.
Is there a waiting list? Are these people coming from Dunn County, the city of Menominee, or how far out are you reaching?
For residential in general.
Yeah,
So right now we do have a waiting list, and we have probably for the last handful of years. I would say it varies as far as how long someone's on the wait list. We do have to prioritize someone if they're pregnant or if they're an IV drug user. So those people kind of get to jump to the front of the line. I would say, so two other things I would say. Our reach is pretty vast because there's not a treatment center in every county by any means. I didn't look at our 2023 numbers, but I know in 2022, we had, people funded from 21 counties. So including, 3 of the tribes. So that's a pretty good reach. It's majority in the western area of Wisconsin.
are some of them court ordered?
Some of them are court
Are
ordered.
they
Yes.
move ahead then, or? Are they?
No.
No, so then you gotta wait in line, even if you're court ordered,
You gotta wait in line.
and your funding comes from,
So it comes from Medicaid, if they have Medicaid. Medicaid pays for treatment portion of it. And then it does not pay for room and board expenses. So that either is self-pay, or if they're county of residence, like Dunn County, if they will pay that room and board portion, then it might be through a contract with the county. Dunn County does include room and board within our contract for, Dunn County residents. And other than that, it could be, if they don't have Medicaid or they're not a Dunn County resident, it could be commercial health insurance or self-pay.
the outpatient, does that cost money for some of the treatments?
Yes, and that's all insurance billable also, so it can be Medicaid, commercial health insurance, self-pay, or again, for Dunn County residents, if they don't have any healthcare coverage and they're income eligible, then we can use county contract dollars to pay for that. Good stuff?
Super good stuff.
Yeah, I'm kind of curious on the contingency management.
Yeah.
And we did a training, did we have a video of that, or we had a training on that some time ago? But how does that like work with the with insurance companies or I mean, because theoretically people are paying to go to treatment, but yeah, if you're paying them, I mean, is it their insurance? Is insurance covering some of that, or is Medicaid covering some of that, or?
No.
Okay, is it sort of experimenting a little bit, or?
So right now, the contingency management approach is nothing that can be billed back to insurance. So right now, what we have to cover the cost is through that SOAR grant, the State Opiate Response Grant, we can use up to $75 per person out of those grant dollars. When it goes above $75, and that's because there's a federal limit set on that. When it goes above that, we got last year, we got a grant from the Community Foundation to help supplement that. There are some funds in our Dunn County contract that we can put towards contingency management, and or we use agency dollars. My view on it is, if it costs us a little bit of money to provide an effective treatment approach, and it keeps someone engaged in treatment, then it's worth it. But to your point, the funding regulations and how things are set up right now with funding does not match with what literature says is effective. So that's a distance.
Yeah, I mean, I thought it was gonna be kind of an uphill battle on that one. I mean, but if it's, over time, proves to be an effective treatment for stimulant use disorder, I think that probably get more support then.
Yeah. And the other thing that literature says is that to get to the level of effectiveness, you have to be spending around $500 or more. It can't just be $50 or $5, you know, the effectiveness part comes in at those higher levels. So there is some push at the federal level right now to lift that amount to be higher than 75, because it's almost like, well, if it's not gonna be effective, why even spend $75 on it? Either fund it to the level of effectiveness that you know, or don't fund it.
What's the, if you are paying out of pocket for residential, what's the cost for that?
So our list price, per diem is 400 a day. And usually we estimate like 28 days. People can certainly stay longer if it's clinically appropriate. People can certainly be discharged prior to that if they don't need to be there any longer. But looking at our numbers, 4 weeks is about the average. So that's usually what we'll ask for upfront. I can't do that math in my head, 400 times 28 days, but, there you go.
He did it in his head.
Oh, nice.
Right over the tip of his fingers.
Yeah, so usually we'll ask that up to be paid upfront, and if they end up staying longer, then we work on a payment plan. If somebody has Medicaid, but they, you know, are not a Dunn County resident, and they don't have a county that will fund them that room and board, our room and board rate is 101 a day. 2,828. And usually we ask for that.
Do you ever take, okay, and this might, Chris, but I mean, might fall in your realm. If you took a total number of, say, how many people are, that should have treatment, 500 people out of Dunn County, and the average cost is X over 500 people, how much money is not, how much is there versus how much should be there to deal with the appropriate number of people? How many, if you had to put a number on how many people were in Dunn County that really should have some treatment, or that go through, the DA's office or the court system, or, how many people are, I'm trying to get an idea of what kind of problem this is, and how do we
Well,
get
I
our
think
fingers around it?
nationwide, I think the data kind of varies, but I think they figure about 10% of the population has a diagnosable substance use disorder. So if you think 45,000 people, 10% would be 4,500 people, in some fashion. What I would say is that, Dunn County and Arbor have a longstanding relationship that's resulted in the ability for basically any Dunn County resident who wants to go to treatment can pretty much find a way for that to be paid for them to go, unless they're just so over, I don't say over income, but have significant enough income and choose to not spend their income that way. But if they're income eligible, the county and Arbor, through a variety of sources, are able to fund that for them.
But if we had 4,500 people at, say, $12,000 person, that's $4.5 million worth of, isn't it?
Yeah, for that, it's assume that every single person would need residential care,
Right.
and also that every single person would want to go to treatment.
It's the numbers, I just, getting the numbers back from Project Hope, and how many people are into meth and other things, and it's staggering. And how many people you must all have to deal with in the court system and such.
It's a really good question, because, what we see are the criminal justice involved people. We don't see the non-criminal justice involved people. So it's pretty hard to get an idea how big that, that piece is. And, maybe they're eventually gonna be criminally justice involved. People are using meth. It's just a matter of time, at least in my opinion. But, I don't know. I mean, how many, functional meth, disorder people are out there functioning and doing great at their job or whatever, I don't. It's just, at least my opinion, based anecdotally, and my experience is that it's just a matter of time, and they're going down the tubes.
And Sarah would be able to speak a little bit more directly to this, but I believe that the most recent round of Sandy's data out of the jail is alcohol's running neck and neck, if not above methamphetamine as the primary. Right? Am I speaking
Yeah,
wrong?
2023 data.
Yeah.
Yes, absolutely.
Absolutely. So I think we can't lose sight of the fact that that's a significant contributor. To
That's
the
pretty
need as well.
consistent over the years as being probably the biggest, problem.
Not so much in that jail population, but it has risen to that in that jail population right now.
And that's an early assessment phase, so it might be more socially acceptable to say that you have an alcohol problem versus a methamphetamine problem as well. So it's just kind of a point in time assessment. But, the reason we're talking about treatment so much is because it's the #1 most prevalent factor in our criminal justice system. And it's also the one that we have the biggest ability to affect and to reduce crime. So that's why we do spend a good portion of our CJCC time talking about treatment options, because it is just so connected to the work that we do and the data that we have locally really pours that out. So thank you for being here today and
Yeah, absolutely. I'm gonna make one comment to your question about kind of trying to quantify. So if you think like 10% of the population has a diagnosable substance use disorder, then of that 4,500 people, there's a very small percentage that actually get treatment. So even looking at our numbers where I'm like, oh, 757 people, like those are great numbers. But if you think, well, okay, so that includes more than just Dunn County residents. The piece of the pie of people that don't get treatment is so much larger than those that do. But it is billable to insurance and Medicaid. And certainly over the years, our reliance on the Dunn County contract has reduced. Now it seems to be going up a little bit more because some people are not eligible to stay on Medicaid anymore. But still, it will never get back to what it was, 10, 15 years ago when we had a lot of people that relied on county funding. But it's a really complex thing. Like we could serve more people if we had more staff. We could fill our 32 beds if we could find more staff to be able to work with them. So part of it is like a numbers thing with budgeting, but then also thinking, well, a lot of those people are gonna have a health insurance plan that can bill for this service. And there again, if you think about a comprehensive approach, not everything is billable. Case management, peer specialists, some of helping them get connected with some of their basic needs. So it's, people always say there's not enough money. But I do feel really good about the longstanding relationship that Arbor has had with the county and really not putting up barriers that don't need to be there for people to get help. Which is not always the case in all county systems, for sure.
Well, one last thing for me is, I appreciate the fact that there are places and that there is this group right here, collaboration. I also appreciate the fact that we just don't say, you're a druggie, we're putting you in jail. A lot of it's mental illness or I can understand alcohol, the way it is. There's a lot of married people in Dunn County and my wife tells me I'm driving her to drink. So, but I appreciate the fact that there are people that are willing to help, take the time to help. It used to be, I think years ago, that, you got into trouble and you go dry out for 60 days. You sit in jail and then you get out and bingo, you're right back at it. At least, hopefully there's some help and it's longstanding help. So I appreciate that, Joe.
Absolutely, thank you.
Thank you so much, Joe.
Yes. Yeah,
Thank you.
mediocre, sorry guys.
It was very nice.
And I always say we're so lucky here in Dunn County to have Arbor Place right across the street.
Yeah, it's right across the
Yeah.
street.
Yeah.
What do you want to? If we could try to, I can do 2 minutes. All right, Sarah's gonna do it all in 2 minutes.
Just want to give a update on our grants. I've got a quick little slide just as a visual.
To share. So we've got a number of grants and some things that are ending and some things are continuing. Just wanna, tune in this group to kind of the bigger picture of what's going on. So we do have, the city of Menominee has a CASAP grant. The Dunn County CJCC also has a CASAP grant. Both of those are gonna be ending in September. So we were notified that the CJCC will be able to continue at $140,000 beginning September or October through September. So that'll be enough funding to really continue our behavioral health officer on the county level. And possibly take over the data management system, pay for that, the core data that the QRT Project Hope team are using. But really just trying to prioritize that $140,000 to keep our Project Hope partners and QRT as operational as we can moving forward. State TAD grant, that's a 5-year cycle, so we're in the middle of that. For 2025, there's 2 million additional dollars that are gonna be available. We can use that for diversion programs or treatment court programs. So that information will be out here not too long. There are some drastic changes as far as how the state is wanting reimbursements, and I'll save that detail for another meeting. We have a DHS state grant, that was substance abuse block grant dollars. That was a one-time 79,000, that one's over. But we were notified our second grant of 103,000 for medication assisted treatment is a 5-year cycle. So we just finished the first year. So we have another 103,000 for MAT. And then the state Department of Justice wants to keep the 5 jail MAT sites going. So they are finding $100,000 starting in January for each site. So there's going to be funding to continue all the newer programs and projects that we've had in the works. So this doesn't include our family treatment court grant. That's a 5-year cycle there. So I guess the message here is Dunn County is looked on favorably because we're using grant money, we're making things happen, and then they want to give us more money to make things happen and keep things going. So that just reflects well on everybody that's participating in that. But it also shows that these are things that are going to be continued to be funded in the future. The state Joint Finance Committee put out their opioid settlement dollars for 2025 and beyond. And there's money specifically for law enforcement, for MAT. The DHS state plan did include those things because there wasn't a demand out there for law enforcement to do medication assisted treatment or diversion, deflection. The state legislature wants to see that happen. So there's going to be more money put towards those projects, and there's just fewer sites participating in them. So that bodes well for us, just meaning more funding for fewer sites moving forward. But overall, the picture's looking good, and we continue to get more funding to continue the projects that we've got started. So that's my grant update.
That's great. And then Sarah included the staff report as well as her very nice and thorough charts and everything on her annual report to the county board. And so she did that. And I think we'll just have to skip agency updates, and next meeting will be large one, August 8th. Okay, thank you all for coming.
Thank you.
Thank you.
Write that up quick.
Sean, I haven't seen you for quite a while. That's right. One second.
Good to see you.
I just